Right, can I welcome each and every one of you to the local COVID Outbreak Engagement Board this afternoon, the 24th of November 2021. Can I please ask all of you that notice of recording, this meeting is being recorded for subsequent broadcasting, and it will be put on our YouTube site, and can I let you all know that members of the press and public may record and take photographs except where there are confidential items. Can I please ask you that those of you wishing to speak indicate by using your chat function or by raising a hand, and only speak when you're called in by myself, if you don't mind. Can I please ask you to switch off your mic and video when you're not speaking? It's got something to do with band. Can I also say that this afternoon, councillors Ian Ward and Bridget Jones, plus Paul Sheriff, who's Simon Dubley, will be substituting. And if I've said your name wrong, Simon, I apologise. And Dr. Islam, of all sent apologies. Now, as you know, I don't normally chair this meeting, but Ian and Bridget are in London, so I've got the honours. So those are the apologies. Can I now ask if there are any declarations of interest or any relevant pecuniary or non-pecuniary interest arising from any business that would be discussed? If you could disclose your pecuniary interest, please ensure that you declare it. And can I ask you that if you have got any interest, please ensure that you do not take part in that agenda item, and any declarations will be recorded in the online details of the meeting. Can I move to item 5, the minutes of the meeting? Can I confirm that the minutes of the meeting held on the 6th of October are accurate?
Great.
Right. The silence, right? Are there any, sorry, I've lost my train of thought all too quickly. Are there any actions from that, from the minutes of the 6th of October that need to be
outstanding ones? No, Councillor Hamilton.
So can we agree that those are, it's an accurate reflection, and then we'll ensure that it's signed off? I know that Councillor Paul Tilsley has agreed, so we don't need to second it, do we? Do we need a seconder, Justin?
Seconded, just to be on the safe side.
Okay. Now, at that point, I just want to say for 1 minute, which is not, it's going off the agenda item, but I need to say a very, very, very close friend, colleague of mine, Penny Olbrook, she passed away on Sunday. Penny was an extremely vibrant member of the council. She was a well-loved member of the Labour group and the other groups. And I just wanted to put on public record that I'm going to truly miss her. She's somebody that I thought we were good friends, and she was somebody that I've known now for 18 years. And she was only 43, but she died on Sunday. And I just wanted to say to the committee that this is a very special woman. She will be surely missed in Birmingham City Council. She worked for the residents of this city, and I just want it on public record that may she rest in eternal peace, and we will miss her. Can I move on to the next item? The COVID-19 situation update. Dr. Justin Varney, the Director of Public Health, will present this item. Thank you.
Thank you, Councillor Hamilton. So I'm just going to run through a relatively pace, just pulling out some of the highlights from the slide deck that has been published on CMIS to give an overview of where we are. And I'll leave to colleagues from the NHS to talk about the vaccine rollout and the rollout of the booster programme, which continues to expand, as well as increasing the access of vaccine to young people, which is rolling out across the city and has been gaining pace over the last couple of weeks. If we look at the current trend, in general, what's happening in Birmingham is we're kind of holding steady state across the city in terms of our case rates. Our hospital admissions are also holding pretty steady. And in some ways, that's good news. There are other parts of the country where we're seeing quite sharp increases in COVID cases. But in Birmingham, we're pretty much staying stable. The bad news is we're not coming down, which is what I'd like to see. So I think what we're seeing is a mixed pattern of the impact of vaccination, which is really reducing the number of deaths, which is good. He's reducing to some extent hospital admissions, but he's having less impact on the overall case numbers. And we are also seeing some improvement now in case numbers in the over 60s coming down, which is good news. In terms of our overall testing rate, that's staying pretty good. And what's really good news is the uptake of the booster dose is now up to 63.5% of people who are eligible for the booster dose have had it. So there's good uptake where people are eligible and they've started the vaccine programme. They are working with us to make sure they complete it and get full coverage. In terms of the pattern and the distribution of cases at the moment across the city, what we're seeing is a very different pattern from perhaps the second or first wave, where the concentration of cases was more towards the centre and east of the city. At the moment, the highest case rates are in the north and in the south of the city, and the centre and the east is faring pretty well. And I think what we're probably seeing is a combination of the protection from vaccine and the protection from natural immunity from people who were infected during the summer months. Now, the concern is, of course, that natural immunity we know wears off after about 6 to 9 months. And so that natural immunity that's protecting those parts of the city is likely to come crashing down in the beginning of next year. And that's the anxiety, I think, of us all across the system, is that just because you had COVID back in June does not mean you're protected for life. And it's really important that people who haven't yet taken up the vaccine do take up the vaccine and the booster when they're eligible, because we are seeing good evidence that it reduces the risk of death and reduces the risk of hospitalisation, and also to some extent reduces the risk of passing it on. So as you can see, in terms of the areas of the city which have the highest case rates at the moment, it's very much the wards in Sutton Coldfield, which through the majority of the pandemic have fared much better than this. And we think this is very much a reflection of the duality of vaccination and natural immunity. And because these parts of the city did not get hit badly in previous waves, they haven't got that natural immunity and they're relying very much on vaccine coverage, which is still pretty good in these areas, but not as good as the combo in effect. And what we're seeing overall from some of the other data we look at, the random sampling infection survey, which suggests across the West Midlands, there is an overall downwards trend. But when we look at the wastewater, although some parts of Birmingham, and it's quite hard on these wastewater maps to see the bit of Birmingham, but we're predominantly in the right-hand picture, the yellow bit towards the south. And then there is a bit of a bald spot where the waste of Birmingham from Aston goes into a different waste system that they can't sample. It's slightly frustrating. But what you can see is this reflects the picture we're seeing in testing, that the majority of the case rates where they're rising are to the north of the city in the Sutton Coldfield area. And one of the reasons we look at this wastewater data as well as the testing data is it allows us to make sure that when testing rates fluctuate, are we getting a good picture? Do we understand what's going on at the moment? And what this is telling us is that overall in Birmingham, the majority of Birmingham, the case rates are stable, but in the north, they're still rising. In terms of variants of concern, the big focus at the moment is on a variant which is known as AY. And this is a variant of the Delta variant. So you'll remember that the Delta variant came around last year and is now the dominant variant across Birmingham and the wider UK. AY is kind of a tweak on the Delta variant. And the challenge with AY is it is more infectious. And even when people are vaccinated, the AY version seems to be spreading more in people who are vaccinated. The good news is that the AY version, the vaccine still stops you ending up in hospital, still stops you dying from COVID, but it's not as good at stopping you transmitting it to other people. So there's a lot of work going on nationally to look at AY at the moment and keep a track of what's going on. But the overall number of cases in Birmingham of AY is relatively low, and these are the total case counts rather than in short periods. In terms of testing, nationally, there is a reduction in the number of symptomatic testing sites. I think most of us are now used to being able to order tests through the post, and that system is working well. So we have reduced, the Department of Health have reduced the number of symptomatic testing sites across the city, and we are arguing hard for those that we've got left to be kept and not have any further reduction in symptomatic testing sites in the city, so that we want to maintain as a minimum, I think it's 6 sites, which would take us back to where we were in the coming into the second wave of the pandemic. Overall testing uptake, symptomatic testing uptake maps what we would expect, in that it's higher in the north of the city and the south, where we have more cases. And when we look at lateral flow testing, we see a similar kind of picture. And we would expect this because, of course, people who've been in contact with a positive case, who've been vaccinated, should be doing lateral flow testing. So again, this kind of follows the pattern we would expect. We've maintained many of our lateral flow testing sites. We still have some challenges around the north of the city with lateral flow, and we've been doing in-reach using supermarkets as distribution hubs to hand out lateral flow kits in those areas. Overall testing rates continue to be relatively stable. You'll see there's some fluctuation of this dark green line, which reflects the impacts of schools. And overall, we're not seeing any particular shifts in trends between different ethnic groups or between different deprivation bands. When we look at the case picture, it's staying relatively stable in terms of proportions, but there has been an increase in the children's age group, and that's particularly in the 5 to 10 age group. And you see that a little bit more clearly in this heat chart, where you've seen for the first time really this 5 to 10 age group really starting to climb quite fast. And at the moment in the UK, we are not vaccinating children under the age of 12 unless they have a clinical condition which meets the criteria as clinically vulnerable. So this is the predominant population that is unvaccinated. And I know there is work going on nationally looking at whether we should extend the vaccine programme down. But what we are seeing is that these high case rates in children are not really translating into high case rates in their parents in the way that we saw in perhaps wave 2 and wave 3. Good is to see that the case rate in over 60s is now stabilising and coming down. I hope that will continue to fall. This is the impact, I think, of the booster vaccination, which has really kind of added that extra bit of reinforcement of the vaccine in the elderly and those with clinical conditions where their immune system is probably not as strong. It's not your body's forgotten how to protect itself. It's that it needs a little bit of a booster class just to strengthen up those reinforcements. In terms of distribution by different ethnicities, we're not seeing, again, any particular big shift in patterns compared to previously. Case rates remain highest in our white population, in our mixed population, but this is a smaller population group than some of the others. So again, no great changes, although some dipping up and down for this mixed band rather than anything else. And similarly, what we would expect in terms of deprivation, some of the most affluent wards of the city now have some of the highest case rates, and that's reflected in this diagram where the IMD10 are more affluent and the IMD1 are more deprived. And so this is very much reflecting the concentration of cases at the moment in the more affluent parts of the city who were less affected in the previous waves. As I said, the NHS position remains relatively stable, but that's a stable level of high burden. I think it's important to really recognise that when we look at the pattern of hospital admissions in the NHS, it's not coming down. This line is staying, unfortunately, pretty stable. This is daily new patients. What's good is that they're not dying, which is good news, but we are already seeing the signs of winter pressures, where as it gets colder, other things go wrong, and we use our hospitals and our NHS services more. So normally coming into this time of year, other NHS activity would be relatively low, so we could absorb the extra pressures of winter. And COVID has eaten up all of that bandwidth. So the NHS and social care are under a lot of pressure at the moment because this overall burden of COVID is not coming down. And now we're building on it with winter pressures. In death data, the death picture, as we would expect, travels about a month behind the case rate data. So what we're seeing now is a reflection of where we were about a month ago. It's staying relatively stable, relatively low numbers. And I think this does reflect the impact of vaccination. And now as the booster programme has gained pace, that will give that extra bit of protection to those that are more elderly and more vulnerable of dying if their immune system's not as strong. And what I am seeing across other parts of the country is significant increases in what are called excess deaths. So the number of deaths above this blue line, which is the 5-year average of deaths for Birmingham. In Birmingham, we're still fluctuating around it. There's nothing here that makes me particularly anxious that we're seeing a large number of deaths much higher than we would have expected in the way that we did in the spring of last year, and particularly in the Easter of the first wave of the pandemic. And that's reassuring, but it is something we're keeping a close eye on, as areas further north have seen significant increases in deaths from non-COVID conditions, more than would be expected at this time of year. So we will see how that progresses at the next board. In terms of situation, we continue to see large amounts of support requested from the public health team, particularly from educational settings, but overall the number of clusters and outbreaks is starting to fall. And we continue to monitor common exposures. And at the moment, as you would expect, given the demographics, these are mainly in schools and education settings. We've maintained our contact tracing partnership and our following up of people by telephone, which if they don't answer, we then follow up with a face-to-face visit. And we have a good success rate in terms of following up. And that has really reduced the number of unknowns or uncontactables over the last couple of weeks. There's been a huge amount of work, and I want to pay tribute to my team and the team within the contact tracing centre at the council who do this work, because 7 days a week, now 365 days a year, we've been delivering this service and following up to support people to ensure that they know what to do to protect themselves and their families. And alongside this, there is also welfare advice available and signposting and support to the financial support and the support from our voluntary and community sector. And it has been a really successful model and a really successful approach, but it is down to the individuals in the team who have these telephone conversations and try to do it in a compassionate and caring way to help citizens navigate what happens when they catch COVID or COVID is in their household. In terms of comms and engagement, we've continued to do engagement through local media and direct engagement with communities, and to promote particularly the vaccine and the vaccine campaign, working with NHS colleagues and using multiple methods of engagement, but also leveraging into Black History Month, particularly with our partners around that, using that an opportunity to refresh and reframe the conversation with our African and Caribbean communities. And we've also been updating our content to ensure that we're staying up to date with what's going on and helping people understand some of the changes that have happened in policy, but also in terms of testing. Throughout all of this, we maintain a focus on trying to make sure that content is accessible, using things like subtitles, but also BSL translation, and where appropriate, also translating into other languages, and continuing to work with our community partners to help give them the information, but also listening to them about what their concerns are. The COVID Champions programme continues to grow and continues to develop, as does our partnership with our faith communities. And we held a special event in early November with Councillor Hamilton and our Muslim community to talk about some of their particular concerns around COVID fatigue. And I know we'll pick that up as part of the public questions. And we've included in the slide set as well some of the detailed work we've been doing in partnership with the NHS in West Birmingham to really focus on some of our areas with the lowest vaccine uptake to try and strengthen the relationships with the communities and respond to their needs. So I hope that's provided a reasonable overview. Happy to take any questions from the board.
Thank you, Justin. The first question comes from Stephen Raybould. Stephen, could you put your camera on, please, and ask your question or make your point? Thank you.
Hello both. So we seem to have brilliant data around the case rates, both in terms of place and demographics. Do we have the corresponding data around hospital admissions and deaths? It seems like that's becoming more and more pertinent as the vaccination program's taken hold.
Thank you, Stephen. Before you answer, Justin, do you want to come in at this point, Andy? Andy Cave from Health Watch, and ask your question?
Sorry, I was stuck on mute then. Yeah, I just wanted to say really pleased to see the West Birmingham slide in the slide pack. I chair the coordination group in West Birmingham, and we're just developing an evaluation report at the moment. So just wanted to say that I'll circulate it to this group when that's ready. And if you'd like myself and a few members of the group to come back and report at the next meeting, we can go into a bit more of the detail of findings of that project as well.
Okay, thank you for that, Andy. Can I go straight over to Justin to make any points or answer the question?
Okay, thanks, Councillor Hamilton, and thanks for the question, Stephen. So we have some data on deaths and hospitalisations, and we are in the process of just finalising the Director of Public Health report, which looks back over the first year of living with COVID. Much of the data on things like deaths takes a while to come through the system. It's not real-time data. So that's where we'll be reporting on the deaths data. We have been working with the hospitals about trying to get more insight into the NHS data on hospitalisation. And there is some both national and local information which we're putting out around explaining deaths in people, the difference between deaths in people who are vaccinated and unvaccinated, kind of helps explain and I suppose unpick some of the fake news that's circulating around it. Ultimately, what we're seeing is that the majority of people who are dying are unvaccinated, and the majority of hospitalisation is in the unvaccinated. Where vaccinated people are dying, I'm trying to think how to phrase this. In effect, they are of an age and a frailty they probably would have died anyway from something else. And as a proportion, they're dying at much low proportion than the unvaccinated. And it's a really big difference between the two kind of volumes of death, comparing the vaccinated and the unvaccinated. The other thing in terms of hospitalisation is we're seeing that unvaccinated people are staying in hospital longer. So even where vaccinated people do get so sick they need to go into hospital, they're only going in for a day or two and then they're fine to come home again. Whereas the unvaccinated people are still staying in for days and weeks and being really very, very unwell. So we're seeing very clear evidence of the differences between unvaccinated and vaccinated. There aren't really any evidence of difference beyond that, because any difference we see in unvaccinated rates, we can link back to what we know about the populations that are unvaccinated. And the final thing to say is that the risk factors for serious illness with COVID remain the same. So people who are very overweight, people who are smokers, people who have chronic diseases, particularly diabetes, high blood pressure, kidney disease, and if it's poorly managed, they are more vulnerable than people who don't have those conditions. Men and the elderly as well. And that's why vaccination is so important, because if you're vaccinated and you're in those groups, you are reducing your risk, whereas you're unvaccinated, you really are facing a real risk of hospitalisation and death because your risk is so much higher. So the key message is get vaccinated, because all the evidence, local and national, says it protects you and it reduces your risk of being very unwell.
Thank you, Justin. Are there any other questions? No, there are no other questions, so we will move on. Thank you. That was a good presentation, Justin. It was very comprehensive. We will move on to the next item, which is item 7, the vaccination rollout and uptake. And Simon, the Director of Primary Care and Integration, and Dr. Islam, but he's not here, the Director of the Black Country and West Birmingham CCG, will be leading on this. So can I Simon, pronounce your surname for me.
Doble.
Doble. Brilliant. Got it. So over to you, Simon. Thank you very much.
Thank you, Councillor Hamilton. So just to take people through where we are really in terms of the winter, the phase 3 booster programme. There are 23 PTN LVS sites in operation. LVS is local vaccination site operating out of Birmingham, and they're carrying out booster doses, but they're also then offering first and second doses for the population that want those. Some PCNs in addition then are also carrying out additional capacity for healthy 12 to 15-year-olds as well, and that's through capacity on the national booking system, and adults and children are able to book through there. Within Birmingham, we also have 18 community pharmacies that are live, and 7 further which are being onboarded at the moment following regional sign-off. So that will grow as another vehicle for delivery. Vaccination centres, Edgbaston Vaccination Centre closed on the 19th. There is work going on to add new centres, and that should happen during December. There has been outside of Birmingham, there's been a vaccination centre open in Solihull very recently, but confirmation of those Birmingham centres should follow shortly. In addition to Pfizer supply, Moderna vaccine has just started to come through into the system this week as well to further support vaccine delivery. From a care home perspective, majority of care home patients have now received a booster vaccination, and housebound patients are being vaccinated by the community trust, with some support as well from primary care. And the flu programme continues as normal through general practice, community pharmacy and NHS trusts. And where possible, where appropriate, co-administration is taking place, but the principle of not delaying one vaccine for the sake of co-administration being followed. So in terms of what is being delivered overall, and this changes as people will have seen, there's been addition to the cohorts this week actually. And the additions this week have been, from a booster perspective, those aged between 40 and 49 now being eligible to a booster post 6 months after their second dose, and also a second dose for the cohort of aged 16 to 17 and 3/4, where they're now getting a second dose as well. The other cohorts then are anyone aged 12 years and older for their first or second or even first dose, if third dose if eligible. You've got the age 16 to 17, as I've just spoken about, age 12 to 17 for the extremely clinically vulnerable. And then certain clinically extremely vulnerable patients will get 3 doses as well as part of that primary vaccination, initial vaccination piece. I've talked about co-administration, so I won't go into that. And just to flag that the schools programme began on the 27th of September, and that's contracted and commissioned by NHS England with school community providers nationally, and that's been flowing through and being supported. The expectation on the schools programme is for that to have completed across all schools by Christmas 2021. There are some vaccination figures within the information pack. They were for events up to the 8th of November and split across the hospital hubs, the local vaccination centres and vaccination centres. Broadly, the lion's share of that, 70% just below, being delivered out of the local vaccination sites, and that's the PCN sites, the general practice sites and the community pharmacy sites, with then 11.5% from hospital hubs and just under 20% from the vaccination centres. So all of that being undertaken. Actions to improve uptake. There are weekly performance reviews across the sites, focusing on activity, and particularly for the local vaccination sites, follow up with any low performing areas. There's been a focus on care home and housebound delivery and understanding how we can progress and smooth through any of the issues that may have been arisen. There's the progression of any of the actions, and this comes back to what Justin was saying earlier, but through some of the vaccine inequalities board and how we support some of the low uptake areas and populations within Birmingham. There's been a system review of Workforce Bureau and redesign of the service to make sure that that's effective, efficient in terms of deployment, and helps avoid any cancellation of clinics. And we're working closely to mitigate any potential risk to uptake due to the change in vaccine levels and vaccine type. I talked about Moderna earlier on. We've got deployment of training and support for the use of that to make sure there's a smooth transition to that coming into the system. And there's a review of local communication strategy as well, and that links back to what Justin was saying earlier. How do we influence patient behaviour? How do we encourage presentation across all of the vaccination pillars? And then encouraging the GP PCN local vaccination sites to engage with the national booking system and therefore widen the ability of patients to access appointments. And Chair, I think I'll pause there and open up for any questions.
Thank you, Simon. That's excellent. Are there any questions? To be honest, Simon, you were pretty comprehensive, but we've got a question from Justin, Dr. Justin Barney, and then Stephen Raybould. If you could both ask your questions, and then Simon, you then answer, that would be great. Thank you.
Great, thanks, Councillor Hamilton. And Simon, sorry if I missed it. Could you just highlight for people two things? One is about the approach for the housebound boosters, and the second is for care home residents, but particularly including children with clinically extremely vulnerable in residential care, because we've had several questions through, and it'd be useful for the board and the public to hear exactly what we're doing with those specific groups.
Thank you for that, Justin. Stephen, straight over to you. Thank you.
Hi, Simon. Just wanted to say, I guess, thank you, because certainly the BSOL approach has been brilliant in getting vaccination strategy into community facing venues. And I know you were really instrumental in that, so that's been brilliant. I wanted to ask you about whether there's any data on the correlation between the amount of distance between where people live and where they have the vaccine, and whether that affects uptake. It seems people are having to travel now slightly further to perhaps get their vaccine, and I wonder whether that's having an impact.
Thank you both. So if I take Justin's questions first, in terms of the housebound patient approach, they're being vaccinated. The majority of vaccination is through the Birmingham Community Healthcare. Primary care are also supporting that as well, and that's down to agreements between the two providers as to how we best manage and support those patients and get that coverage across. And there's ongoing work around that. The second part, Justin, I'm going to take that question away just so that we can get a more appropriate answer around that in terms of supporting some of the children's homes, because I want to just be absolutely clear on the current approach around that for you, but we'll take that away and come back on that. In terms of care home patients, the majority of those have now received the booster. Those are mainly supported through general practice again, and quite a structured approach through that. But that is really well progressed in terms of the care homes position. In terms of Stephen's question, I think in terms of our local sites, we've done really well within Birmingham. In terms of maintaining those local vaccination sites, other areas have seen quite a marked drop off from general practice no longer providing those vaccinations, whereas within Birmingham and within Solihull, actually, we've maintained that level of coverage and managed to hang on to those sites. What we've also then done is seen a huge increase in the number of community pharmacies. So whilst the vaccination centres, as I said, we haven't necessarily got those operating currently within Birmingham, and we're looking at those reopening soon, we have got from an individual site perspective far more sites actually available. So without having the data specifically, Stephen, I would say from a site perspective, we've got more than we had during the earlier delivery phase.
Right, thank you. That's quite a comprehensive answer, Simon. I've not actually got any questions for you because Justin stole my thunder. I was going to ask you about care homes, so because there has been some misunderstanding re care homes. No, Justin, you're the boss. I know when I'm beaten. So that's excellent. So Simon, on that note, thank you very much, and we will move to the next agenda item. Right, the next agenda item is around living with COVID, the strategy. Now, Dr. Eddie Anyuwaki, I think, the consultant in public health, will give an update on this item. So, Eddie, can you come in, please?
I think I'm covering this, Councillor Hamilton.
Are you
apologies.
Yes.
No, it's my fault. Eddie's somewhere else.
Okay, it's over to you then, Justin. Thank you very much.
Thank you, Councillor Hamilton. So colleagues will be aware we're continuing the work to develop the Living with COVID strategy. This has taken a little bit longer than we'd originally anticipated, partially because we've been doing a series of exercises, both in Birmingham and across the West Midlands, to test our winter resilience and test our thinking in this space. So what we've included in the slide deck is a bit of a kind of reflection of where we've come from. So initially we were working through the emergency response framework. Then over the summer of 2020, we developed the local outbreak management plan. That was then updated in relation to the national contain framework. And that contain framework, I think, has been updated 3 times over the last year. And we're now developing the Living with COVID strategy, which really is a strategy to take us through from where we are now to through the Commonwealth Games, because Birmingham does face a slightly different situation to the rest of the country in that the Commonwealth Games will bring to Birmingham the world. And that is a great opportunity for the city, but it also means we need to consider the challenge that the COVID pandemic across the world is unlikely to be over by the summer of next year, despite my hope that in Birmingham we'll be in a much better place. So we have done quite a lot of analysis of the last year, and the slides just give you a flavour of what will be finalised and brought back to the board in December in terms of looking at the overall pattern since March 2020 and how we've gone through the waves, the impact on hospitalisation, the deaths, and the challenges across the city, the case rates, where the lockdowns occurred and where we were. Some of the analysis, and in the report there's more detailed analysis on ethnicity, for example, as well as by geography, but also looking at the case distribution and how that's changed over the last year, and the pattern of the impact on our working age and our older populations. And I think I just pause here to just highlight that although in the first wave, we very much saw COVID hit our care homes incredibly hard, we should keep in mind that it wasn't until the summer of 2020 that we really started to provide testing across the wider population. So in the first wave, we were very much testing in hospitals and in care homes, but not a lot of people outside of those settings were able to test. So we're not sure how good that orange line, which is the under 60s, really reflect what was going on. From the second wave onwards, it is the under 60 population that has dominated, and particularly in the third wave, which is the spring the late summer of this year, you can see the impact that vaccination had in pulling down the case rate in the over 60s. And that was similarly reflected in the death impacts of this third wave, whereas the case rate in the wider working age population shot up. So we've been doing some reflection, much in the way we present on a monthly basis, but we've looked back over the whole year to look at what's been going on and what lessons can we learn. Also looking at some of the details of the death data, and this is what I was alluding to, Stephen. When you see this report at the next board, you will see some of the analysis we've done looking at a year's worth of death data, which we're able to do and allowed to do in more granular basis than we would be able to do on a monthly basis, which is quite interesting because it looks at both the risk of death by ethnicity and the risk of death on your right in purple and the risk of cases by green on the left. And there are some differences in the ordering about where death rates are higher, but case rates are not as high. And the Caribbean community is a good example of this, where the case rate on the left is towards the lower end of the chart, but the risk of death is highest. And that's an important kind of thing to flag, I think, particularly reflecting some of the communities where vaccination uptake has been more challenging. And so we've seen more deaths continuing in the communities which are less protected in the second and third waves of the pandemic. So just moving on to the strategy and where we are now, as I said, it's a strategy we're aiming to bring to the board for final ratification in December, and the draft will be given to board members by email probably in the next week and a bit for comments before it's finally locked down. This is really setting out our approach for the next phase. As we move from an emergency response phase into an ongoing response to the pandemic, we need to recognise the pandemic has not ended. And as part of the Living with COVID strategy, we've thought about different scenarios and different ways this could evolve over the next couple of months and over the next year. Much of what we're seeing at the moment is that parts of the city that were hit hard over the summer are protected by a combination of vaccination and natural immunity. But at some point, that natural immunity will run out. And there's a real risk that we'll then see an upsurge. And those are the kind of things we've considered in terms of developing our approach. The key strands of the strategy around thinking through how we maintain our specialist public health function and our response within the council. And we work with the newly formed UK Health Security Agency as they've evolved from Public Health England, how we continue to develop and improve our use of data and intelligence, and particularly our use of insight, our work with communities and with our community and voluntary sector to really understand what are the barriers, what are the issues that are impacting people day to day on the streets of Birmingham is really important to this moving forward. That we need to continue to bring a coherent approach to support of people isolating, and that we need to continue to develop and evolve our community engagement mechanisms and address the challenge of that most of us are bored and fed up with talking about COVID and would really like to talk about something else. Underpinning this are a series of approaches and things we've considered, and we've included that in the slide deck, and there is a slightly updated version of this that will be uploaded on CMIS later today. But I wanted to give colleagues a sense of what the priorities were and how this was evolving, and as I said, at the next board we will hopefully bring the final version of Living with COVID for ratification to the board. Happy to take any questions.
Right, any questions? It is an ongoing, for me, this document is a live document at the moment, and it is ongoing and it will change, I believe, as time goes on. But at the moment, Justin, I've got no questions because I think it's pretty straightforward. And to be honest, you have been sort of telling us as we've gone along what you're doing. So I don't think anything in the document is the first time people have heard from it. So don't be upset that you've had no questions this time, but we've got no questions. So what we'll do swiftly, we will move on to the public questions submitted. They were submitted in advance. Now, it's got on my agenda item that I'm leading on this. So that makes me laugh. So I'll do an introductory statement and I will hand over. Will you be doing the presentation? Right. A number of weeks ago, many of you on this board will have had the information that we lost a young woman in the east of the city. She had her baby and died of COVID. That brought a sharp level of interest from our Asian brother and sisters and other communities. It wasn't just the Asian community that were very, very concerned. And so as the local council, we were asked if we would lead on a specially held meeting relating to COVID and how we could improve and increase people's awareness of COVID, but more so taking the vaccine, especially pregnant women or women that have just had their babies, because we had noticed through data that women are not taking the vaccinations the way they need to be taking them. So we had a special meeting of the imams and others. There were doctors on the call and other professionals and NHS England and large numbers of, we had public health staff, myself and others. It was a well-attended meeting. So at the meeting, I always forget the word that they use. What is that word that they used at the meeting?
COVID fatigue.
That's it. At the meeting, the imams and a number of people kept using the word COVID fatigue. And at the time, it just struck a note with me, because within the communities, and those of you councillors and others that do a lot of work in the community, I'm finding that in communities like mine and in the ward I serve, I can't even talk about COVID. If I open my mouth, they call me the COVID queen. And if I open my mouth and say, have you had your vaccine? Are there any issue? Oh, councillor, don't keep going on about it. And it's as if I started to feel that people did not even want you to talk about it. So when I heard the term COVID fatigue, I asked officers if we could look at putting a question or some questions out there to see what responses we would get relating to what people were feeling, what was the mood at the moment within the community, but to help us drive forward this particular subject, really how we can increase people's education levels so they'd want to take the vaccine. But we also then, in the top 5 wards, which I am embarrassed to say, but I'll put my hand up, my ward is one of them. We are one of the lowest rates of the COVID uptake, the COVID vaccine uptake. So with that going on, and with what the imams were saying at the meeting, I am going to hand over to Justin, because this is what the public health team then did. And they did a phenomenal piece of work in a very short space of time. So over to you, Justin. Thank you.
Great. Thank you, Councillor Hamilton. So what we were able to do is use our social media channels predominantly, and also work with our community partners to signpost people in to our social media channels and the Be Heard consultation portal to ask questions, to really ask people, what do you think? Are you feeling COVID fatigue? Do you understand what that term means? And what do you think we could or should be doing differently? So we launched this on the 19th of November, running through to the 22nd. So really running over the weekend, over a period of about 72 hours. And we got just under 100 responses, which is great. And I think is a good example about how we can use this kind of methodology and this kind of approach to just get a snapshot, get a flavour of what's going on for people. So the poll questions we asked were 3 questions. So we know that many are tired with the same messages, and we must act now to help everyone get through these tough times. Help us understand what COVID fatigue means to you. So I feel COVID fatigue, I don't feel it, or what is it, with the 3 questions, 3 options. And then question 2, what is causing COVID fatigue? And question 3, what can we do to support each other to address COVID fatigue? So we tried to frame this in relatively simple terms and make it quick and easy for people to respond to on Twitter or on Instagram or through the survey. The limitations, we need to be honest about that. It is 96 people, so it's only a kind of snapshot, and it may be a bias sample for the people that are on social media over the weekend. So it can't be said to be representative, but it gives us a bit of understanding. I think it reflected to us that the term COVID fatigue, although we might use it quite a lot, many members of the public think of COVID fatigue being about long COVID. Not about people being bored with COVID messaging. And that's quite useful feedback, because it's important to remind ourselves that sometimes we slip into jargon, and COVID fatigue is a bit of a jargon phrase used by government. But actually, for most people on the street, that doesn't necessarily mean anything, and they think of it more as a symptom of COVID rather than being bored or tired of COVID messaging. So when we look at what did we find and the kind of key findings, so 67% of those who responded to the online polls said they felt COVID fatigue, and only 16% said they didn't. 18% said, what is it? So that's useful, and a useful reflection about kind of, it reaffirms what the masjids were telling us, and what many of the community partners have told us, is that people are a bit fed up of talking about COVID, and we need to think about different ways of doing it. When we asked about what's driving this, what causes the fatigue, there were kind of these 5 themes that came out. One, erasure for trust, and some of that linking to changing messaging. So particularly things like face masks, where in the first wave, we didn't think the evidence base supported them, but now we know that of aerosol transmission, face masks and face coverings are really important, as is ventilation. So that's because we've learned more about the disease, but what people are feeling is this is government can't make up its mind, and that erodes the trust. People talked about there being the challenge of there's no end in sight. Every night on the news, we get a briefing on the COVID numbers, and it just feels like it's going on and on and on, and that's wearing people down. There was disappointment over the vaccine. And I think some of that's that challenge about how we balance messages, particularly national messages, that vaccine is really important, but also help people understand that no medicine is perfect, and this isn't a silver bullet, this isn't a wonder drug. It is making a huge difference in terms of the number of people who are dying from COVID, and a really, really big difference. But it isn't perfect, and it doesn't solve all of the challenges of transmission, and it doesn't mean everyone's protected 100% of the time from ending up in hospital. Some people shared thoughts about that some people believe and behave in a way that the pandemic is over when it isn't, and that being really challenging and conflicting messaging about that, and others that they feel unsafe and they worry about others, and that kind of pressure of the stress and anxiety is causing that fatigue with the messaging. When we ask people about, well, what can we do differently? What should we be reinforcing? So there were responses which talked about keep taking precautions, help people think about things that are easy and simple to do, like wearing a face covering when you're on a bus or a train. That's not a particular hardship for anyone. We've been doing it for most of last year, but actually we know that wearing those face coverings in enclosed spaces, particularly spaces that are poorly ventilated, really does reduce the risk of transmission, and that helps protect other people as well as protecting yourself. Keeping consistent messaging is important, and that's something that came through, but also reinforcing the messaging around volunteering and taking community responsibility. Even though we're in a different phase of the pandemic, don't lose the links you have, those neighbours that you checked in on to check they were okay during the last couple of waves, keeping that up and that being an important part of this. Localisation was important, and direct action. And I think we've heard quite clearly some of the stuff we've done in Birmingham through the pandemic, publishing data at a ward level in the way we do, both on vaccinations, but also in cases, and being so transparent on our data is something that we've heard from communities, from citizens, is really important. And I know in many other parts of the country, they aren't able to do this. This is something that Birmingham really has led the way on, putting data out there and helping people see what's really happening in their part of the city, as well as in the wider picture. Using things like digital advertising, really talking about that return to business landscape and how do we factor this into return to business in a way that's safe and appropriate, and also looking at messaging and using things like social media influencers in a different way, but also kind of trying to make the messages louder but less frequent, and not barraging people and bombarding them with COVID. When we asked about again views on kind of where the messages were getting confused or weren't landing in the right way, that kind of mixed messaging, changing messaging came through. Thinking more about how do we frame it in an asset base, and I was reflecting a bit on this with Councillor Hamilton and others a couple of days ago. We have to remember that in the first wave, the prediction was 3,000 deaths in a best case, 9,000 in the worst. That was the first wave prediction. 18 months on, we are just over 3,000 deaths. We have done incredibly well as a city, and we need to celebrate that. We need to talk about some of the fantastic stuff that has been achieved through COVID. The way the NHS has enabled people to still access primary care every day through the pandemic. The way we continued to support people with domiciliary care and social care every day through the pandemic and navigated the challenge of a disease that we really didn't understand, that was brand new just over a year and a half ago, is fantastic. And we need to kind of play up those positives a little bit more and be a bit more asset based. On the flip side, we need to remind people that this is still a serious disease and not kind of get it, let it be turned into a cartoon or a gimmick. We need to remind people that sadly, it's still taking lives in our community. And that focus on localization and less frequent but louder came through really loudly from the feedback. So that gives you a sense of what we found from those 72 hours of engagement. What we'll be doing with that is that's feeding into the Living with COVID strategy, and it's feeding into the refresh of the comms and engagement plan that my team are working on, that's led by Madupe. And that will be rolling out really over January with a new start to the approach to support a slightly different style and a slightly different approach to engagement, because sadly, COVID is still with us, but this kind of insight has been really valuable. So I'm really grateful to everyone who took part. And I thought I was really pleased that Councillor Hamilton pushed us in this way, because it has stretched my team, but it's helped them see the value and the opportunity for this kind of snapshot engagement, helping to inform and develop our approach. Happy to take any questions on it.
Right. I will be calling a few of you in just to hear what the different sectors are thinking at the moment, but we'll start with Andy and then we will go to Stephen from the community side of things, because it'll be interesting to hear, because I was fascinated by this. But Andy, over to you.
Thank you very much, and thanks for the presentation. I think it's a really useful reminder and insight about what communities are thinking at the moment, and where we've felt for a while that there's some kind of community fatigue around the word COVID, and the feedback from our community groups is that actually they're really struggling to start that conversation with people now because people are fed up. This gives a real good initial insight around what we can do differently, and in particular, I think the next step is how can we use this as a system, really, not just the public health comms of it, but actually how can we support that in the wider system. And maybe in the B-Sol vaccine inequalities group, it would be useful to go there to look how we can do something different collectively as well.
Thank you, Andy. Can I go to Stephen if he's prepared to say a few words? And Paul, I'm going to call you in, and then Simon, because I just need to hear what the different bits of the world around COVID are saying. So, Stephen?
So there's a couple of things, really. I think one of the things to say is, coming up from the community groups, yes, there is fatigue about having a head-on conversation about COVID all of the time. There's still lots of energy around the wider determinants of health, which feed very heavily into the COVID outcomes. So having a conversation around COVID and those wider issues, I think is certainly worthwhile. I think the other thing is the real challenge, especially around face masks, that that other people are not wearing face masks is a real disincentive for the people who still want to do it, to wear the face mask, because everybody knows they're protected by what other people do, and finding a way to turn that round would be really helpful.
Thanks, Stephen. Paul, your reflections? Paul Tilsley, Councillor.
Yes, yes, I'm with you, Paulette. I think that there is a degree of fatigue. However, I do religiously send out the public health update, and I also take the latest figures for Sheldon that are published at 4 o'clock on a Friday afternoon on the government COVID site, and I send them out to my database. I have not had anybody respond to me and say I'm no longer interested in the information. The only negatives I've had have been from people who have moved out of the area and don't want to be on my database anymore. So and I do get every week at least 2 or 3 people saying thank you for the information. So I can only speak as I find, and the database has got 300 email addresses, probably reaches 600 people, maybe a little bit more, and I know that it does get forwarded on to other people as well, but that's my experience.
Right. Thank you for that. That's really interesting. I wanted to bring Simon in. I don't know if he's still on the call, but it would be interesting to hear what Matt Bennett, Councillor Matt Bennett, or Richard Burden. I just want to hear what people are thinking out there from their experiences, just to help public health. Simon?
So it's a really interesting topic and a really interesting presentation, actually. I mean, I would agree with some of the things that both Andy and Stephen have said. In respect to Andy, I do think it would be helpful to play this conversation into the dialogue that we have within the Vaccine Health Inequalities Group, and get their views on it, actually, and also how we play it into our wider communications program around vaccine uptake as well. I think those would probably be my two messages back, Councillor Hamilton.
Fantastic, Simon. Richard, what are your thoughts?
Yeah, I agree with what's been said. I think the presentation was a really, really useful one. And I think going forward, it is going to be important to kind of reality check that in our ongoing comms work and relationships as well. I mean, I think some of the things that come out of that presentation, you know, are very, very, I mean, it's certainly key with the sort of anecdotal impressions that I've got. But I think the lessons probably go beyond COVID as well, and they need to, you know, inform our work in a wider way. So I think it's a really, really good presentation, and feeding that presentation into some of the other inequalities groups and others, I think it's a really good idea.
Thank you, Richard. We'll definitely take that on board. I don't want to call anybody out else, but Sarjit, is he a member of your team, Justin? Sarjit Taka.
Sergit, yes.
Oh, is it
Yes.
Sergit? Yeah.
Yes, hi, Councillor. Hi, Justin.
Team.
Yes, I'm part of Simon Robinson's team, so just been
Okay,
collating the
well,
it's been very interesting.
Is there anybody else before I move on to the next item? As I've said, this has really interested me because we are, is it 18 months along, Justin? We're 18 months along, and I've been on this road with Dr. Varney from day 0, and we've fallen out, we've made up, We've been like an old couple in this particular subject, but the one thing we've been is consistent, that if we need to get the messages out there and we need to get out to the community, that we will do that. And this for me was another example of public health and the wider council working together quite quickly through residents and what we were hearing from the public to actually do a piece of work that I think will be quite informative going forward. So I just want to thank Justin for that, and I especially want to thank the Dupe and the team that they really weren't happy with me last week, but they did it and they did a fantastic job. So I publicly want to say thank you to you all. But now I don't want this to be the end. What I want you to do as you're going forward and you're taking things to other areas, could I ask politely that it's brought back so that people know what is being said out there? Or it could be that this group is just looked at as a little talking shop, that we're not really going out to the public and getting the information from them. Okay, so on that note, I am going to move on to the next agenda item, the test and trace budget overview. And again, I've got Dr. Eddie Owaku.
It's me again, I'm afraid.
And it's you again.
Yeah, it is me again.
And basically this one we need to agree. So over to you, Justin.
Yes, thank you, Councillor Hamilton. So this is the budget overview. So this is, the board is asked to note this paper. We will, as you know, we've been doing work on the budget, and we will be bringing a slightly more detailed report to the December board to sign off some of the changes that we will need to make in the budget for the remainder of its duration. So the funding of the work that we do in this space comes through a ring-fence grant from government under what's called the Contain Outbreak Management Fund, the COMF. And we have a dispensation from the Department of Health to profile this budget to the end of September 2022 to ensure that we have appropriate response and support and resilience for the Commonwealth Games in relation to COVID and to see us through the next wave. We have been very fortunate in a sense that we have bid for various pots of money through the last 6 to 10 months, and we've been successful, and that's somewhat destabilised the budget because we've actually secured an additional £2 million that we weren't expecting to have when we set out the original budget proposal. So although at the moment it looks like there's a big underspend in the budget, in reality what we're finding is that some of this is because things have not been coded into the budget code correctly during the second wave of the pandemic, and I'm sure colleagues will appreciate the amount of pressure that staff were under. So the fact that they were coding them to normal budget codes, not to the new budget codes, is understandable. So there's been a piece of kind of retrospective accounting going on to work out what spend went where and why some of these budget lines that we were expecting spend against, it isn't there. And we've identified already several areas where the recharge that should have gone to these budget lines hasn't happened. So when we bring the report back in December, I'm hoping to be able to present the board an update on the budget, which I'm confident on, which will be accurate in terms of the spend to date, but also a reprofiling of the remaining budget to provide assurance to the board that we will have resilience to take us through the Commonwealth Games and maintain the specialist public health response and the enhanced enforcement and environmental health response that we need to protect the city through to the end of September next year. So apologies we weren't able to do that in time for this meeting, but as I said, there is quite a lot of forensic work that we're doing to make sure that we're not missing any of the recharges and that we're ensuring that things are being coded to the right budget lines. You're on mute, Councillor Hamilton.
Father, thank you for that, Justin. Can I hand straight over to Stephen Raybould, who's got a question?
Given the extra pressure that the Commonwealth Games will put on the public health situation, is there additional investment coming into the city to support that?
I wish I could say yes, Stephen. As far as I'm aware, we have not received any additional funding to local government public health for the Commonwealth Games. There has been a small amount of additional resource given to the UK Health Security Agency, UXA, to maintain some additional health protection response capacity for the West Midlands. So there has been some to the regional teams, but there's nothing additional. As I said, we did get a special dispensation to carry forward this budget. And one of the things that Birmingham experienced that some of the other parts of the West Midlands didn't is you remember when we went into the tiers model, each time we went into the tiers, we got an extra 3 million because of the size of population, which we weren't expecting. So the first year of the pandemic, we didn't have to spend as much of this budget as areas that didn't go through the tiers. And that left us, when we came into this year, with a bit of an underspend. So what we got is agreement for the department to carry that forward. I would love additional resource to take us through, but what I'm making sure is I can ensure the city is safe and protected based on what we have today. If we get anything more, then we can do more. But I'm trying to operate a prudent accounting approach to this based on what I know we definitely have.
Justin, can I follow on? And thank you for that, Stephen. That was actually an excellent question. Mine was more about the short term. Justin, at the moment, we're going into, well, we're in the worst winter we have ever known. And as the hospitals have all told us that they're at capacity already, the fact is that within our NHS, they are running at full pelt. Adult social care are saying that the numbers that they're seeing coming through their service are the numbers they would normally get after Christmas. Knowing government and NHS England and what have you, the way I know it's no longer in the protection agency, the way that I know you know them, are there any soundings to say that probably pots of money could be coming through just to help us through this very difficult period where, as you've alluded to, after Christmas we could be looking at a spike in numbers because natural immunity is waning, and we've been doing the data shows what looks like it'll be happening in Christmas. Because if we're already at full pelt now, and if we're looking that after Christmas, natural immunity will have gone. So it means that our numbers are going to shoot up. Surely that is tsunami territory, potentially. Is there any planning for that?
So I'm not aware of any additional funding being identified by the department. I know that both from the NHS and social care sides, there are requests around additional support because winter pressures, we're already in winter pressures. I mean, let's be clear that the pressures in health and social care at the moment are what we would normally see mid to late December. So we're already under the cosh as it is. And that is burning through reserves and capacity, as well as burning through what resilient staff in health and social care have got left. So I know those voices are being raised by colleagues in adult social care and by the NHS, but I'm not aware of any murmurings or whispers on the winds that there is additional resource coming, nor do we have any clarity on the public health grant allocation for 22-23. And so part of the reason that I take such a cautious approach to accounting in this space and hold back a contingency and a reserve is that I have no confidence that at this stage there will be help coming, and therefore if we can keep a small amount of buffer, it will help us see us through. And that's why we're in a better financial position today than we perhaps would have been if we'd have been a bit more reckless with our spending earlier in the year. So I'm hoping that the board will support my cautious approach to accounting in this space, because I fear that there will not be additional finances released by government, and we do have a hard winter still to get through.
Okay, are there any questions? No. Justin, I would like to thank you for the reports you've given this afternoon. Excellent. And is there any other urgent business from anybody that anybody would like to raise this afternoon? I've got no other urgent business, and there are no responses, so I'm presuming not. The date of the next meeting will be on the Wednesday, the 15th of December at 2 o'clock, 2 to 4 o'clock. It'll be online and it will be the last meeting for the year. And can I now say exclusion of the public? Do we need to exclude the public at this point, Justin?
No, Councillor Hamilton, there are no private items for today's meeting.
Okay, and so on that note, can I thank everybody for coming along today, and thank you all for putting up with the change of time, and again, thank you. I've given you a little bit of time back, so you will have the leader next month. I was just a pleasant interlude, but the boss will be back next month. And on that note, enjoy the rest of your afternoon, and I'll speak to you all soon. Thank you very much.
Thank you, Paula. Take care.
Pleasure, Paul.